And so I'm going to welcome everyone. My name is Melissa Baldwin. I'm with Florida Clinicians for Climate Action. This is our August meeting. We're so pleased to have you all. If you haven't yet, please go ahead and type your name, the city you're joining us from, and your specialty or area of expertise into the chat. And I'm still admitting a few folks here. So let's go ahead and get started. As I mentioned, this is being recorded and we will make it available later on our website. So at Florida Clinicians for Climate Action, we work to engage health professionals to learn about the health harms of climate change and to advocate for equitable policies. I want to share just another quick slide with you to show you a few more things. So welcome to Racial Disparities in Climate Health Outcomes. As I mentioned before, I'm Melissa Baldwin with Florida Clinicians for Climate Action. Sorry, this slide is not advancing. Bear with me on this technical difficulty here. We wanted to teach you all a little bit about climate change. This is really one of our goals, is to engage clinicians to learn about climate change. And we have a helpful mnemonic called Heat Wave that helps us remember the 8 ways that climate is affecting our health. And so I want to share that with you. And if the sharing does not work, it'll be easy enough for me to just go ahead and email that to everyone later. So in addition to learning about health and climate, I wanted to point out just a few quick things. Climate change is harming our health right now. It's hurting some people more than others. And if we do nothing to address this problem, it will only get worse. And so that's why I'm super excited to talk with you all about climate change and specifically about racial disparities and climate health outcomes. So with climate change, it's really important to remember a few key things about the science. One is that the scientists all agree. 97% of scientists agree that climate change is real, it's happening, it's bad, it's us, but there's hope. Number 2, think about greenhouse gases like a pollution blanket. So when we drive our cars, we burn coal and oil and electric plants, we are polluting heat trapping gases. So that heat trapping pollution is affecting our health. And the third thing is just that it's not necessarily our fault. So in fact, there's actually bad actors in this situation, and those are the polluters. And in fact, did you know that about 1/3 of all of the heat trapping pollution in the world can be traced back to just 20 companies? So fossil fuel companies have known for decades that their product is harming us, and yet they've consistently denied the science and funded a disinformation campaign. So that's why we want to engage clinicians to learn about climate change, enhance your climate literacy, enhance your confidence in talking about the ways that climate affects health, and really encourage you to advocate for solutions, to advocate for, to hold polluters accountable and to protect vulnerable communities. So, I wanted to make sure, again, I just point out that we do have a couple of events coming up that I want to encourage you to check out if you're interested. We have, if you live in Miami-Dade, I am seeking focus group participants for a climate health and equity focus group. I'm going to put the link to that in the chat. Also on the 21st, August 21st, our parent organization, which is the Medical Society the Medical Society Consortium on Climate and Health, is going to be doing a webinar on nonprofit advocacy. So the do's and don'ts, we're approaching a very important election. And so making sure that nonprofits have a safe space to work in to be advocates during this upcoming election. And then on the 24th, one of our partners, the Alliance of Nurses for Healthy Environments, they have a water quality webinar. And at the end of the month, we have our advocacy meeting, and for that, we're going to be talking about Medicaid expansion. So I'm going to, if I can here, I'm just going to try and chat again the links to those meetings. So having said that, I want to see, we have a few more people joining. I want to thank our partners for supporting this event, and thank our steering committee members as well as our parent organization for being here. And now I'm going to torch you for only 8 minutes with a recorded video. I wanted to start this conversation. The reason that I organized this meeting is because I was really compelled by the study that came out in JAMA in June. And so the authors of the study are Dr. Bruce Bekkar and Nathaniel DeNicola. And they published a paper in JAMA about the association of air pollution and heat with negative pregnancy outcomes. And so I've edited this footage. I've got it down to just 8 minutes. But I do want to encourage you to visit the website to see the full presentation because it is a good one. It's actually available for a CME credit. And so I'm going to show you that video now. And then after I show you this 8.5-minute video, we're going to go ahead and do our panel. Sound good, everybody? Thumbs up? Questions? Any issues? Chat me in the chat if you have any issues. All right. Let's see how this goes. Okay. I'm going to share this. I'm going to hit play.
Last October, the JAMA was interested in publishing studies about the climate crisis and its impact on health. And notably, they...
Is this showing okay? Thumbs up if you can hear it, see it? Okay.
Calling for papers, particularly on vulnerable groups like children and the elderly, the poor, those without insurance, people with chronic illness, but pregnancy was not even mentioned as a vulnerable group. And given the amount of literature we had come across, we thought it was really important to submit to them. And in fact, upon submission, we were accepted by the journal and very, very pleased to see that not only did they publish the article in its entirety, but they also highlighted the findings, which are essentially that these impacts are specific, these exposures across the United States. Out of the 68 studies, 84% of them, 57, showed a significant positive association between either the air pollutants or heat and preterm birth, low birth weight, or stillbirth. And these are large studies, by and large, over 560,000 births per study, and in total over 32 million, again, across the United States.
So looking at the question of air pollution on these OB outcomes, preterm birth, low birth weight, and stillbirth, from a variety of different angles, kind of almost any way you approach it, the result was the same, that there was this significantly increased association. Again, 48 of 58 studies. When you break it down by topic, 19 of 24 studies on preterm birth showed increased risk, 25 of 29 on low birth weight, and 4 of 5 studies on stillbirth. And among these groupings, the lowest number of total births in all of these were 5 million. So the volume, the N for these studies was certainly there to be compelling. When we looked at heat, this was an area that was less covered in the literature. So there were only 10 studies on heat and our OB outcomes of interest. However, 9 of those 10 showed, again, a positive, significant increased risk. 4 or 5 studies on preterm birth showed increased risk, and then 3 of 3 studies on low birth weight, and 2 of 2 studies on stillbirth all show the same message coming through. And this here is a diagram, an infogram of what's called a heat island. And this is actual data. So you can kind of see that the downtown areas have a much more concentrated impact of heat at the 95th percentile, whereas when you get out toward the rural areas and farmland, it does kind of taper off. And this geographic distribution was something that's shown through in quite a few of our findings and in other research. The other element to mention here is that while we were looking simply at exposure and outcome and so reporting associations, a number of other studies that came through in our conclusion do suggest some biologic plausibility. In this study of 1.1 million live births in Pennsylvania, they found essentially a dose response between proximity to a fracking site and risk for low birth weight. So if you lived within 1 kilometer of a fracking site, your risk for low birth weight increased by 25%. When it went out to 3 kilometers, that risk was increased by 10%, and then at 5 kilometers, it was back to baseline. One of the more encouraging studies that we came across, again, not included in our review, but part of our discussion on plausibility, was the experience from California retiring coal power plants. Over a 10-year period where these coal power plants were retired, the preterm birth rate dropped just over 25%. And this, I say, is encouraging because when you think about an intervention that a maternal fetal medicine or high-risk OB specialist could do to reduce the preterm birth rate by 25%, there's almost nothing. This is an incredible impact. But also, when we think about plausibility, it's one thing to see an exposure tied to an outcome, but then when you remove the exposure and the outcome also changes, it makes you take those findings a little more seriously.
Another feature of our data that was a bit surprising, we didn't go looking for it, but it certainly jumped out at us, was the studies that found racial disparity and made note of that. And in particular, in terms of air pollutants and preterm birth, out of the 24 studies, 10 of them noted racial disparities, and 8 of those 10 found a highest risk for Black moms. In terms of air pollutants and low birth weight, similarly, 10 of 13 studies that noted racial disparity noted it highest for Black moms. And overall, Black moms seem to be more than twice as likely to have adverse outcomes as did the next highest category, which were Latina mothers. So again, this was not something that we went looking for, but Nate and I discussed this before the article was published, that might be something that we would end up talking about, because all of a sudden we were in the midst of the Black Lives Matter movement. And this is such an important topic to be considered when we discuss our results and when we consider their impacts, is the fact that certain subpopulations are particularly at risk, and that problem needs to be resolved. So we were very pleased to see that the New York Times picked up on this, as did a number of other major media outlets. That maybe one of the most compelling things, aside from the fact that the climate crisis seems to be directly associated with bad outcomes within the United States, but also that it wreaks particular havoc on at-risk groups, not surprisingly minorities, who face so many other of the social determinants of bad health on an ongoing basis. Our own Joe Biden ended up tweeting about this the same day that the study came out. So obviously his campaign team is paying attention to the news cycle, and made a very important point that we need to address not only the climate crisis, but in particular those groups that are getting hit the hardest and the first, in order to really make this right.
When we look at interventions, they really do span the entire gamut from the clinic to Capitol Hill. And we think it's important to mention both of these because there are individual actions that can be done. There is some agency and empowerment that providers can talk to patients about when it comes to avoiding some of these adverse outcomes. So, for example, one of the biological mechanisms that was highlighted in our heat research was that dehydration was a kind of fundamental underpinning to things like preterm contractions. And this is one of the most common things that women's health providers talk to their patients about, whether it's Braxton Hicks contractions or dehydration as the cause. We could spend more time talking about this during specific heat waves or during what we know will be hotter times of the year. Likewise, many of their physicians and disciplines talk about air quality index in a much more detailed way, that women's health providers could take this cue, and we could be more deliberate about talking about air quality advisories and timing of outdoor exercise, as well as the importance of indoor air quality. However, I think we know there's a limitation to how far those individual actions can go, and the impetus, the burden really can't be on pregnant mothers to change their outdoor air quality or change the temperature they face. We need system changes, and we have done these things before. Anyone who's ever approached the field of obstetrics and delivering women's healthcare has lived by this mantra of healthy mom, healthy baby. And as we improve things like air quality and clean water and less toxins in the food supply, we can achieve this healthy mom, healthy baby, which actually begins with our healthy environment.
Okay, so I want to just pause there. We had several new people join, so welcome to this discussion. We're so glad to have you all here. My name is Melissa Baldwin. I'm with Florida Clinicians for Climate Action. We have a wonderful panel to present this evening, and I'm going to go ahead and kick it over to the panel. And I also will note, I will keep trying to put, I do encourage you, if you have time, to watch that whole presentation. As I mentioned, I just gave you a few snippets of it, but there's some great content in there. So having said that, I would like to introduce our panelists. Tonight we have Chelsea Four. She's a doctoral candidate with Jacksonville University with a focus on infant and maternal mortality, and she's a member of the First Coast Black Nurses Association. Also joining us, we have Rogers Kane. He specializes in family medicine, and he is the former president of the Northeast Florida Medical Society. Also joining us, we have Keisha Collins. She is an OBGYN with Community Healthcare Systems. And we have Dr. Jeffrey Goldhagen, who is the chief of the Division of Community and Societal Pediatrics and president of the International Society of Social Pediatrics and Child Health. So let's make sure that all of our panelists have their audio working. Rogers, are you there?
Yes, I am.
Awesome. And Chelsea, are you there?
I am.
Great. And Keisha, how about you? We don't hear Keisha. How about Dr. Goldhagen? Are you there?
Here.
Okay, Keisha, I'll call on you last, and I would encourage you to try to call in using the phone number, if that'll work for you. I chatted that to you in the chat, and hopefully we want to make sure we hear from you. And text me too if you still have trouble. So I am going to go ahead and kick it off. I'd like to start with you, Chelsea. Can you please tell us a little bit about your dissertation on infant and maternal mortality?
Thank you, Melissa. At first, and again, I'm honored to sit on this panel with all the distinguished individuals here, and also, more importantly, everyone who sacrifices time to access information on this topic. Last year, I recently had an opportunity to participate in the Fetal Infant Mortality Review Project here in Northeast Florida. And the review was done based on 147 cases of babies that died in 2018. The FIMR identified that 31% of those deaths were related to perinatal conditions, 21% were sleep-related, and 20% were prematurity and low birth weight related. They also identified that the greatest perinatal risk periods were during maternal care and maternal health and prematurity. While they didn't really give numbers in the report of the exact number of affected Black moms, the report did indicate the disproportionate impact on Black moms. We also know that the social determinants of health have only increased in disproportion for Black moms. In the report that we were just watching with Dr. Bekkar, he also indicated that the disproportion was too significant not to address, and he mentioned those articles and those findings. So, and again, to kind of talk a little bit more about my project in itself, my DNP project in itself, I'm currently newly a part of a task force through the Northeast Florida Healthy Start Coalition, which is examining the underutilization of prenatal screenings. And what we're hoping to accomplish is increasing the number of screenings being done by all OBGYN providers. What we currently know is that Northeast Florida currently has a screening rate of 53.8% compared to the state average of 70.1%. So having identified this, it is also evident that we are not screening all patients. Now, the prenatal risk screening is a mandated screening that should be done for all patients, all newly pregnant moms. And what we're seeing is that a lot of providers are either for inherent bias or just are not completing the screening for lack of, possibly for lack of knowledge, not knowing the effects of completing that screening and referring those patients. And I think that it is closely associated with the health disparities that we are seeing.
No, you reminded me actually of something that Keisha emailed me, and she is having trouble connecting to audio. So I'm going to ask another panelist to speak, and we are going to keep trying to get her to join, that talked about racism, even in the way that mothers are treated. And if they're treated by a Black doctor versus a white doctor, that the outcomes are better, which I was really shocked to see that. But we're going to keep trying to get Keisha on the line. In the meantime, I want to go ahead and ask you, Dr. Goldhagen, what did you think about this presentation? Can you share your thoughts with us? And also, how does this affect, in the field of pediatrics, how does this early start affect childhood development? If you could comment a little on that.
Sure. Well, I appreciate the opportunity to participate this evening. And I don't know if everybody received it, but I think they did in the link that there was there was Dr. Bekkar and DeNicola's actual study, and there was something really very profound in their discussion. It says a recent study from California suggested that particulate matter exposure alone was associated with an equivalent amount of the racial disparity, Black versus white, in preterm birth rates, as did other demographics and social factors. I think that statement was probably the most profound takeaway from this whole evening, and that is that the air pollution is equal to all other any other social determinant of health with respect to addressing or causing the disparities that we see in between Blacks and whites in birth outcomes. And that is astounding. It's profound. And what it says is that climate change equals poverty. It equals racism. It equals all other social determinants of health that we know contribute directly to the impact of on birth outcomes of Black women versus white women. But having said that, then I think there's a really historical context to all this, and that is the impact of social determinants on birth outcomes. A guy named physician epidemiologist named Sir Michael Marmot started this work in the 60s, so that's 50 plus years ago. So we've known that social determinants of health have a critical impact on health outcomes. The ACE children's studies, the adverse childhood experience studies were more than 25 years ago. So we've known from the ACE studies for 20 to 25 years. And now all of a sudden, over the last 5 years or so, now we have woken to the fact that social determinants of health have a critical impact on health outcomes. And so if we assume that all of us are in the meeting this evening are health professionals, then the question that we have to ask ourselves is, have we known all of this for so many years, and now we know that the impact of climate change is having the same impact or equal impact as other social determinants of health. What are we going to do about it? We haven't done anything about it over the last 50 years, right? And particularly in the United States. So are we going to now, in a fundamental way, transform what we do and how we practice our health professions? And so that's a question that we have to ask ourselves. Are we going to change? It's not to say that there's certainly that clinical aspects of what we do, which we get paid for, right? Those have to change, but also our systems, our focus on systems, and our focus on public policy. And we can look back, right? So we've known all of this. This is not new. We've known it all. We just now are understanding it as more as it relates to climate, but we've known all these issues before. The International Physicians for the Prevention of Nuclear War won the Nobel Prize for saying that nuclear war is in fact a health issue. The International Campaign Against Nuclear Weapons, ICAN, also won the Nobel Prize for their work on that. We've known about lead and the impact of lead and the differential impact of lead on communities of color. So this is not new. I mean, this is what we've known for literally decades. And the question is, are we going to respond? And you know, and as you said, Melissa, physicians and healthcare professionals have a very, very powerful voice. And we have to decide whether we're going to respond or not. But we're not going to respond, and we're not going to succeed on the basis of our previous biomedical paradigms. The only way we're going to respond, and the only way we're going to succeed, is if we reframe what we do and how we think and how we respond in the parlance and principles, using the parlance and principles of human rights and social justice and health equity. And so there are a few existential issues that we need to address, one of which is climate change, one of which is globalization, one of which is war. And so we have the opportunity now, actually, it's not just the opportunity, we're at a critical juncture. We either respond and survive as a species, or we don't. And COVID is a perfect example. It's not COVID that's causing the issue. It's COVID serving as a lens to magnify the inequities that we've known have existed, that which we've ignored. Climate change is another lens, right, to identify and magnify the inequities that we've known have existed, and we have a choice, and it's up to us. And you know, when we talk now about Black Lives Matter, we've known over the years that Black lives don't matter, and neither do Hispanic lives. And so, you know, it's up to us at this. It's up to us at this point. And climate change really serves as a foundation and framework to make the fundamental changes in how we think about health and how we practice, not only for climate change, but across the spectrum of existential issues that are impacting us.
Thank you, Jeff. I want to, you teed it up perfectly for me to go to our next panelist, Rogers Kane. And you asked the question, so what do we do? Can we change? Dr. Kane, what do you think? You know, what is the role of clinicians in getting engaged on issues like this?
Well, you know, clinicians, nurses, and especially nurses and doctors are the most trusted sources of information as it relates to health consequences of climate change. What we're not doing is getting the message out there and relating it to our patients. I no longer see pediatric patients. I'm actually on the other end of the spectrum. But because of the people that I do take care of, they represent a multi-generational household. They see we have the grandkids, the great grandkids, and you know the grandmothers all in the same household. And so, what as physicians, many of us already in our professional associations believe we must get involved with public and patient education, and to get them to understand that climate change is very relevant to direct patient care, because now we're beginning to see some of the harmful effects. When you said you were surprised you saw the difference in terms of race as it related to the effects of the climate change that was played earlier, the video that was played earlier, I am not surprised. If, institutional racism has had its place in medicine just like anywhere else, and because of the black and brown position in society, the lack of wealth amongst us, we're kind of put on the back burner. As Jeff was saying, black lives and brown lives don't matter is what it appeared to be. And a lot of it was not intentional in terms of people going out, even though there's a faction that is, but people going out and wanting to perform racist behavior, racial activity toward someone that doesn't look like them. But I think it was just lack of knowledge and lack of understanding. And I've used the old cliche cultural sensitivity that allowed them to perpetrate this lack of care and awareness as far as how climate change is affecting both, especially the Black and brown communities. If you look at, since Jeff used COVID as a lens, if you take and look at the distribution of death from COVID and overlap that with the distribution of death and the heat wave back in Chicago that occurred 25 years ago, is almost a direct overlay in terms of the location of death, the highest death rate, highest places of death. So it has been around for some time, and as clinicians, we have got to take the lead role in terms of making the community aware and holding those politicians whom only want to see us every couple of years so we can go out and vote for them, hold them accountable to making some progress to these racial disparities and inequities as we see fit, especially with climate change going forth. When we see extreme weather, who's going to be hit the most other than and the most and the least prepared? Those are the Black and brown. When these, as in mothers that are the pregnant ladies, when they start getting dehydrated, the whole dynamic of the pharmacokinetics change in terms of how these drugs react to that mother and the fetus. And so things that normally may not cause her problem will begin to cause her problem. For instance, if they're on any diuretics for one reason or another, they may become extremely dehydrated during periods of excessive heat. And because of the lack of funds, the lack of equity in terms of wealth distribution, may not be able to cool down as easily as the people that are on this panel by turning up the air conditioning, because they may not be able to afford electricity that's associated, a high electric bill that's associated with trying to stay cool. I looked at my last month's bill at the house, and I saw the most recent bill that was like $150 difference. And and I didn't think we use air conditioning that much more, but it's that time of year that if they can jack up the prices for utilization of electricity. So I think one last thing, what we did see most recently with the Republican convention when it tried to find its way in Jacksonville, all those physicians, including myself and Jeff, that signed on to the statement that we did not want them here under the circumstances that it may spread COVID. It made a huge difference, I think, in terms of the mayor and the rest of the city council listening. And so as clinicians that are being on the front line of the impact of climate change on our patients, the very young and the very old. I'm on the very old side. As I got older, so did my patients. But the impact that it has on them, we're right there on the front line, doctors and nurses. And so we should be out there delivering the message to those that have the power to help make a difference, especially locally. Now, the 20 companies that you referenced earlier, I think that's a more global thing that we have to take on, but it starts locally, grassroots efforts, and then hopefully we can just blossom up and make some changes and make a difference.
Yeah, that's excellent. Thank you so much for that. And I do agree with you. I think that if we make enough noise that people will start to listen. And I do applaud you for that letter that you all wrote, and the work that you did. And another point you made about energy efficiency that I want to follow up on as well, because that's exactly the type of work that I want to engage you all in, is advocating for access to better home improvements to help make homes safer to live in. But also at the state level, there are laws in place that require the polluters to actually spend a part of their profit on helping low-income folks be able to afford their electric bill. And that's the type of thing we advocate for here at FCCA. So I'm gonna try Keisha here. I'm gonna ask you to unmute yourself, and hopefully we're gonna be able to hear from you, Dr. Collins. Let's see, let's give it a try. Can you go ahead and unmute your phone, Dr. Collins, and let's see if we can hear from you. Dr. Collins, again, is an OBGYN with Community Healthcare Systems. Hello, can we hear you? I'm clicking a button here.
Can you hear me?
Yes, we hear you. Welcome. Thank you.
Thank you. I'm going to get back to my Zoom screen. Just bear with me 1 second.
All right, thank you.
Okay, I'm getting to that. Okay, can you see me and can you hear me?
I see you. Yep, I can see you. Thank you so much, Dr. Collins, for joining us. So yeah, I wanted to ask you.
Me through the technical difficulties.
We've figured it out. It's good now. So I wanted you to just reflect on your experience as an OBGYN, and also just, share any other thoughts that you'd like to share on the panel.
Yes. So first of all, I'd like to also say thank you to my fellow panelists. It's been a pleasure listening to everyone, and this is such a needed topic and very timely. Thank you to all of our participants this evening, and Melissa, thanks for the invitation to participate. So first of all, I wanted to start out by saying that in 2018, the American College of Obstetrics and Gynecology actually published a position statement regarding climate change and its impact on women's health. And it really kind of went through, in addition to looking at environmental factors such as actual air pollution, but also looking at other things in terms of food deserts, water safety, environments that could also impact our outcomes and our health. And so this is an issue that, honestly, as a medical student, you're so focused on the practice of medicine that the public health and population health side of how we can contribute to things really is not something that is promoted probably as much as it should. And so that doesn't have to stay the same. We have a responsibility to really work with our patients and work with the community. And having been in practice now for some time, I had the privilege of getting my MPH before I went to medical school. And so I do have the good fortune of practicing with a public health mind. And so as we think about climate change and its impact on our community and in terms of our nation, we really have to practice with a public health mind and a population health mind. And in addition to that, there are several good comments mentioned earlier about the role that we play. So I'd like to introduce 3 words. I like to do things that are alliterations. And the first one is how we do things in terms of being a catalyst. As a physician, we're definitely focused on taking care of the patient in the clinic at the bedside. But at the same time, we have a responsibility to interact with our community to understand what's going on at the heartbeat, the things that are really affecting our patients in order to make that change. And so as healthcare providers, as physicians in particular, we have a responsibility to act as a catalyst. We know that these things are occurring, but how do we translate those problems into solutions and interventions? And we have to be the drivers for that. And so in that respect, being a catalyst is something important that we should be regularly engaging in. The second C would be collaboration. So as we think about things like air pollution and water quality and housing, of course, we have a degree in medicine. And so in order for us to be able to communicate the concerns of our patients, we also have to work very closely with the community leaders. We have to be involved in the associations regarding the housing authority to help be at the table in terms of making those decisions. And the third C is how we take care of our patients. As I mentioned, a lot of our focus and training is on the bedside care, but also that care needs to extend, or advocacy in particular needs to extend all the way to the Capitol. We need to be involved in policy because a lot of times the people that are making the decisions that impact our patients, that impact the air quality, that impact pollution, they may not be privy to the information or the experiences of our patients. And so we have a responsibility to communicate the experiences of our patients to the policymakers, be a part of the decision in order for that to make a difference. As an OBGYN, I really could tell you lots of stories of how, things that impact, for example, preterm birth. But the one thing that I wanted to mention is a lot of times, whenever something happens with a patient, particularly if there's a history of a prior preterm delivery, you try to collect all the information from that scenario in order for you to be able to do things differently the second time around. And a lot of the factors that we know are an issue are difficult things to change. We talked a lot about the example regarding dehydration, and I wanted to throw out the scenario to you because I've had patients I've seen on triage that have come in 33 weeks, they're contracting, and we talk to them, and they've been at their job on their feet for 14 hours. They may work at a fast food facility where they don't have required breaks, and they may not have a water bottle with them. And so, of course, they're coming to you. A lot of times they show up at 2 a.m. They've worked a full shift. They've been on their feet. Now they're hurting. We check the urine. Of course, they have ketones. We can tell that they're dehydrated. And immediately we start to PO hydrate, and sometimes we IV hydrate. So again, that dehydration is, of course, exacerbated by their social situation. If they already have 2 children at home and they're taking care of an elderly family member, they may have to work. And so really, when we start to look at how these issues impact our patients and our outcomes for our moms and our babies, they really have to be a very comprehensive approach, because we have to be able to address literacy. Is this a mom who did she finish high school? Does she only have a GED? Is that why she can only work at a fast food facility? Is that why she can only do this particular job? And so we really have to look at those things together, and then we have to go upstream quite a bit. I agree with the sentiments expressed before, which mentioned the fact that COVID really has it's exposed the fault lines in our healthcare system. I read that quote in a magazine and I loved it, because the things that we're seeing were already here. And it's important for us not to just be completely distracted by COVID, but to realize this is really an opportunity for us to use this outbreak to work together in ways that we had not before. There's a Wells Fargo ad that I saw this weekend that talked about how we rethink how we care. And this is a great opportunity to do that. And so really, as we really start to think about, how we make a difference. I mean, we can talk about the problem. We know what the issues are, but I'm ready for us to be creative about how we really make a difference in that scenario. And there's some things where we have to do one-on-one. I mean, I work with patients and I counsel and we make changes, and I, try to build, help them work with the environment they're in. But also a lot of the changes that we're looking for need to happen at a policy level. And we need to raise the awareness so that our patients can also become advocates for themselves, even in these very issues.
That was beautifully stated. Thank you so much, Dr. Collins. I really appreciate all of the points you just made. I want to open it up now for comments and Q&A. We have about 15 minutes left in this meeting. If you are an audience member and you want to share a thought or ask a question of our panel, either raise your hand, use the, should be a little raise hand button on the bottom, or you can wave your hand physically at me. And in the meantime, okay, Dr. Holder, go ahead. It's our founding co-chair, Dr. Cheryl Holder. Go ahead.
Good evening, everyone. I want to thank such a great turnout for this topic, which is so important for all of us, and for inviting you to participate more in FCC if you're in Florida, because we want to do more of this and encourage our clinicians to do as our doctors have said, and Chelsea, about getting involved and using our voice to speak for those who often can't. And so I thank you. I also want to bring up a new article that I saw, and you can comment on it, which takes it even worldwide, that with this pandemic, we have seen the largest reduction worldwide of preterm birth. And what happened with the shutdown was air pollution improved overall. And also, I think our moms got some rest. So I see this data supporting more what we've seen previously that we just saw the 8-minute video on. And how do we then take this to more policy where we get maternal leave, where we continue to push for improvement in climate, but in taking better care of our mothers, where they should not work as long as they do work while they're pregnant. Because this has been the biggest reduction, and it's worldwide, not just in the US. I don't know if anyone else has seen that.
Does anyone want to comment on that?
So I do want to make a comment. This is Dr. Callens, and I'm really happy that you brought up that point, because I really think one of the things that is really important is how we improve reliable access to reproductive services. And you know, I've had an opportunity in the last probably 2 years to do a lot more preconception counseling, which is something that sometimes is hard to get to, because usually you're seeing patients when they're already pregnant. But because I have such a large GYN patient base, I'm seeing patients a little bit earlier. I'm able to do that education a little bit earlier. And so one of the things that's really been an issue is, or concern for me, is how our ladies access that. And what's happening now, I can foresee it, and you may be seeing this already, with the shift in terms of economics and job security. There are a lot of people who used to have coverage and regular access that are not now looking for other sources for healthcare, or we have people who are delaying their entry to care because of their concerns. And so really the access issue is really changing. And it's important for us to continue to educate and encourage our patients to really take ownership of their health. But we also have to make it easy for them to get to us and for us to take care of them. And what happens sometimes, as often in medicine, is we get so focused on acute care that we forget about the preventive services. And that's one of the things that I'm battling now in my community, is making sure that we're still offering contraception and STD screening. And you know, if someone has hypertension, making sure we take care of that before they get pregnant, because a lot of times the medications need to be different. There's so much that we can do if we look at women's health in a very comprehensive sense and not just focus on the obstetric care.
Mm-hmm. Good point. And I think Dr. Kane, did you raise your hand? Did you want to add to that? Oh.
Well, since you asked, I'm too a believer in a preventive care, and that the world didn't stop because of COVID, even though sometimes it appears that it did, because all people think about is COVID, and I can't get, we don't tend to see patients following up as well as they should, and before you know it, they're going to many of them may wind up in our emergency room, either from having some heart-related issues or strokes, heart attack. But I'm on the other end of the spectrum as it relates to maternal and pediatric well-being. However, that still is in their household, and as the young lady mentioned earlier, as Dr. Keisha, I think is what it was. As Keisha mentioned earlier, those mothers have to work an extended amount of time and prolonged amount of time for whatever reason, maybe just because they have to take care of their extended family. So I really encourage people to let people know to still seek their usual health care despite COVID.
Mm. And I see we have a question. Oh, go ahead. Did you want to respond to that, Keisha?
Yeah, I'm just going to add one more thing. So the other thing that I'm seeing a lot now is, because our moms are working so many hours, our grandmothers and the other women in the family who usually would be kind of transitioning out in terms of duties are doing a lot of childcare. They're taking care of their families. So I have a lot of grandmas who are primary, and what happens sometimes with that focus on taking care of the family, they put themselves on the bottom of their to-do list, if even at all on the list. And so I'm seeing a different impact as well on our grandmothers, who are such a critical part of the community, and how that impacts everything. So when we think about, you know, air pollution, how that impacts our older moms, or wiser moms, as I say, who may have some pre-existing comorbidities, and how that impacts them, that really there's an opportunity for us to really do so much in terms of education and our outreach.
Mm.
Well, I challenge that. You know, we're talking around the periphery of the issues. I mean, what you're talking about is structural and institutional racism. And so we do have the opportunity to talk and educate our families and so on and so forth, but they don't have the capacity to make the changes. And so, ironically, if as a group of health professionals, if you look at any profession at all across the board, we're at the least risk. right? We can go out and do whatever we want to do as far as advocacy, radical advocacy, or whatever. There's no risk for us. If you take a look at every social movement that makes a difference, that has made a difference in our society, whether it's civil rights or voting rights or women's rights or gay rights or animal rights or tenants' rights, you can just go on down the list, are all based on a human rights framework. So we're not talking in my venues, right? We don't talk about children's rights. And in the context of what we're talking about here, we're not talking about climate rights. And so if we're going to make a difference, it's not to discount the fact that we can talk to our families and we can educate women and so on and so forth. But that's not where the change happens. It's not where the courage happens. It's really getting out there and advocating and for fundamental changes, human rights changes. The issue that you're talking about, having maternity leave and so on and so forth, are fundamental issues of racism, justice, and equity. And so, I think we do ourselves a disservice, a huge disservice as physicians, by talking around the subjects and talking in ways that our mentors have asked us to talk about or suggested we talk about in the past. And nothing's going to change unless there's a radical redistribution of wealth and a radical approach to what we're doing. And as everybody said, it's true. We have a powerful voice, especially female physicians and nurses have a very powerful voice, but it's of no value whatsoever unless we use it. And the data is pretty clear. The data is really clear. We contribute, the healthcare we provide contributes about 10% to health outcomes, maybe 20% to health outcomes. So while we spend our time focused on the 20%, we lose the opportunity to address the 80%. And so that's where I think we need to find ourselves, addressing the 80% in a transformational way that we've not chosen to pursue in the past. And as a result, in the U.S., every health metric in the U.S. is the worst amongst high-resourced countries. And so we have a choice. We have to make that choice, or otherwise, 10 years from now, 20 years from now, when you're as old as Rogers, not as old as me, although I'm older than Rogers, but when you're as old as Rogers and I, you'll be asking the question, why haven't things changed? And the answer is pretty simple, because the transformations that need to happen in the system, we just neglected. So I would ask us to rethink climate change and think in terms of climate rights, and how do we become radical around climate rights.
Yeah, Jeff, I think we've gotten old enough now that we can see that we don't see any risk of us getting out and being radical and just trying to make a difference, and not be afraid of any. I'm not afraid of any personal outcome, and I think I think you're absolutely correct. We have to call a spade a spade. Excuse the pun, but that's what we have to do. And if we don't, we're going to be, like you said, 20 years from now, still hearing the same drum beat, and nothing has changed. So.
I have a couple other questions. We're almost at time, so if people have to leave at 7:30, they can, and if people want to stay, they can as well. But there was a question for Chelsea, and also Shelley has her hand raised. So, but before I move on, is there anything else on that topic?
I just want to pick back on that before I answer Dr. Neal's question, and what is in the literature. And Dr. Bekkar actually said that medical voices are being amplified. But I do think, and again, just piggybacking on what the other doctors are saying in here, is that Black medical voices, it's time for Black medical voices to be amplified in our community. Our communities most impacted are playing leading roles in the solution. So it is imperative that we create plans and develop initiatives that are successful and sustainable. And again, those are some of the things that we are looking at with the initiative that related to the infant mortality is what has worked, and not just related to infant mortality, but what other platforms, what other awareness programs have worked. Like we've seen, like smoking cessation has had a huge impact in the decrease of smoking because that awareness, what they're doing, is working. I saw Dr. Neal ask a question, and it brought this study up that I read earlier, or this article that I read earlier. But in order for us to eliminate health disparities as a whole, it's going to require examination and ownership of our past works, and also examination of our future focus, like finding a focus in our community, impacting from the inside out. And as we address those factors that contribute to health disparities and social inequities, we have to look at the environment. We have to look at the culture of those that are experiencing those disparities. Well, there was an article in The Hill by Justin Coleman, I don't know if anybody else saw this, that stated Black newborns are more likely to survive when cared for by Black doctors. All right, a study published in the Proceedings of the National Academy of Sciences found that Black babies were 3 times more likely to die in hospitals than white newborns when cared for by white doctors. And I only reason why I'm mentioning this again, and again with Dr. Neal asking about those, what things can be done different, what are the literature saying? A lot of this is starting to come to the forefront of how we need to start working from the inside of our community out. And again, I know that is what a lot of the panelists are also saying, that the impact and the change has to happen inside. We need to care for our community. I wouldn't even, I'm sure that there is literature on the same that can be said is true about Black patients that have Black doctors. So, just getting out there to make that impact from the inside out instead of waiting for a change to externally happen to change what's happening in our community.
We are at time. If people want to stay, I'd love to stay. There was a question, a hand raise that went away. Does that person still have a question? I don't remember the name.
I have a comment, actually.
Okay, sure.
Thank you so much to the panelists, and respectfully, I'd like to speak to Dr. Goldhagen's challenge because, and follow also of Dr. Ford, Chelsea's statements that the populations that the physicians treat are social voices, and the social impact that a physician can make starts with the way that patient is treated and experiences their health care, but also how they experience the things you're passionate about. So if climate and health is something a physician is passionate about, their experience with the patient should reflect that, and the patient should understand that their voice as a voter has a very big and very important impact. And that right there is a fundamental part of how physicians can impact and advocate. So your voice as a voter matters, but so does every voter that you provide physical health care for. And I appreciate you all being here.
Yeah, and I thank you so much for saying that, Vicki. And that's one of the ways that we want to be a resource to you. Make it easy for you to educate your patients, provide literature, posters, fact sheets, tear sheets. I have these packets of these tear sheets that we made. This is the heat wave mnemonic I was telling you about. It's just a helpful way to remember how climate impacts health, and talking about climate change matters, and talking about racism matters. I recognize we're in this moment where a lot of Americans, I think, are being awakened and trying to come to grips with how much more work has to be done to address these issues. And so talking about it, having the conversation, raising your voice, encouraging, talking about climate with your patients, but also just talking about it amongst yourselves. There's a lot of research that only 7% of people actually talk about climate change with friends and family. Nobody talks about it, and nobody knows about it. Like, generally the public is completely clueless on, most people think it's caused by like plastic or the ozone layer. And so there's a lot of work to be done on education. And I do appreciate you making that point, Vicki. Are
I
there
have to
any?
follow up with the
Sure.
voting. It's so
Yeah.
important that we vote. And there are many doctors' offices who have voting information. Some offices have had registration. Now it's a little late, but you can start helping to educate folks on how to vote with the vote by mail, to get it in early, or that there'll be drop boxes at the election sites. So folks are comfortable, even if they get the mail-in ballot, to be able to vote. And that's been done in many positions and offices. It's not illegal. And even with a 501c3, you can educate. You don't have to say which party to vote for, but you can encourage people to vote and encourage folks to understand what the issues are and how the climate and the changes that we're seeing is affecting their health, and have them do the work. And that's where we have the literature and they can educate themselves. And as clinicians, we have that role that we can in our offices. So it's November, it's the time to vote and to respect the science and vote for the science.
Mm-hmm. Thank you for saying that.
Dr. Holder, I totally applaud that also. And that reality that your patient is a voter also and can do the work, it is so impactful. It's why a physician's role is so important, knowing that there's health issues at risk when voting for someone who does or doesn't realize climate change is a reality. May not occur to the everyday individual, but for them to understand their overall health experience, the physician is their greatest resource.
Mm-hmm. Well, we are, thank you so much, everyone. Thank you especially to our 4 panelists for your time and sharing your expertise. Thanks to all of our steering committee members and our loyal members who've been joining our meetings. I want to really encourage you to engage with our group. We're advocating for Medicaid expansion. We're advocating for energy efficiency, retrofit, and policy to help low-income people be able to afford their electric bill. And I want nothing more than to raise up your voices. And my background is in public relations, so I love working with you to write an op-ed or write a letter to the editor to help you to lift up your voice and to speak out for change. So please think of FCCA as a partner, as a resource to help us, work together collectively to make a lot of noise about racial inequities and climate health outcomes, and to ask for that change. And I believe that we can create that change together. I want to give a couple shout outs. I see Angelique has joined us with the Dade County Street Response Team. They're doing great work in Miami, helping underserved people get access to testing, to care, to essential services. I want to give a shout out to Dr. Fred Anderson, who is developing a fabulous medico-legal partnership on climate and health. Again, this is a way that you can advocate for your patient directly. And actually, my Jacksonville folks would like to know this is modeled off of successful work in Jacksonville, a medical legal partnership advocating to put screens on housing to help with issues related to mosquitoes, and they passed a screen ordinance. And so join our group, become a member, it's free. And I'm going to put our URL in the chat. I also just want to thank all of you for being here. Does anyone have any final comments from any of our panelists or steering committee members? Oh, and I want to give a shout out to Mark Mitchell, who's the reason I'm here today and one of our founding members for Florida Clinicians for Climate Action. And Mark is doing great work across the country, creating sister groups. So we're here in Florida, but we have a Georgia Clinicians for Climate Action, Ohio Clinicians for Climate Action. And so we have a lot of sister groups. So if you know clinicians in other states, I would encourage you to see if there's a Clinicians for Climate Action in that state. So any final comments from any of our panelists or our steering committee?
Well, just to thank you for all the great work you're doing. And, we're at the beginning of this journey, and we wouldn't be as far as we are now without your help, and we wouldn't go as far as we can go without your support. So appreciate it very much.
Well, thank you.
I concur.
Thanks so much.
It's my pleasure. And please make sure you join as a member. I'm going to put our website, floridaclinicians.org. Visit, become a member, get my emails, open them, please, and take those actions. And then you tell me how I can help your community. If there's an issue in racial and economic, is there the polluter in your town, a coal plant that we can call out for polluting? That's what we want to do. So I'm grateful to all of you for your time. Thank you.
Thank
Hey,
you.
Melissa, I want to make one quick statement. A lot of people that were on the line were not necessarily clinicians, but they were interested in the topic. So you probably saw quite a few non-clinicians, but they were sending me messages that they thought that this was a very interesting topic, very informative.
Well, I'm glad, and I realized too when I came up with this idea to talk about this, I think that for a lot of our panelists, you know, this is not new, right? These racial disparities are not new to you, but maybe for the general public, it is something that they're not educated on. So I really appreciate you taking the time to talk through it and to talk about it and to share this knowledge. And this is a public recording. It will be on our website. So hopefully we can get more members of the public to listen and to learn. So thank you for saying that, Dr. Keene. Are there any other Go ahead.
Yeah, this is Dr. Campbell. I was going to say, in full disclosure, I am from Georgia, so I'm just a neighbor.
That's okay. We welcome you. We're all the South, right? We're inclusive.
That's right.
That's the other point I want to make. We're very inclusive. So we want doctors, nurses, med students, please join us. You know, we're a very inclusive group. Any health professional voice, we want to work with you to help you grow your confidence in climate literacy and understanding the science, and to make statements publicly about advocating for climate action and to help reduce the pollution that is harming our health. So thank you to all of you. All right, I'm going to conclude the meeting. Thank you everyone for your time. I'm very grateful. Check out our website, join, become a member. Bye everyone. Thank you.
Bye-bye.
Thank you.